mother. The mothers of these patients are the most remarkable people, and we're very grateful to you all. I'd like to introduce speaker for this evening, Dr. Fisher, who's homegrown at from Silver Spring, was graduated from University of Miami with a degree in microbiology, did medical school at the University of Maryland, internship and residency at Duke University, went to Rochester for her fellowship in cardiology, and then Strong Memorial for adult genetic disorders. She came to University of Maryland in 2001 as head of women's adult cardiovascular disorders, and then in 2011 has been director of the adult genetic congenital disorders of the heart, where she also runs the fellowship program. But I can tell you that every one of my patients who has the privilege of having Dr. Fisher as her doctor just raves about her. She is a wonderful, wonderful doctor. So thank you very much for coming this evening, Dr. Fisher.
Thank you for such a beautiful introduction, and I have to say it's an honor to meet a lot of the people here in the room. I think I'm probably the one person who hasn't met everybody in the room, although I've had many, many phone conversations about specific patients or groups with people here in the room. And this group has made an amazing difference in the understanding and care of patients throughout the world. As you've heard, but also as I see every day in my practice and as I learn every day in my practice. One of the best parts of being part of this group in this practice is really learning every day, learning from not only the literature but also from the patients and from people in multiple disciplines. So I think of care as multidisciplinary and crossing a lot of the boundaries that we have between adult and pediatrics, between surgery and medicine. And again, it translates to better care for everybody, and it translates to better learning. So when Dr. Henderson said, would you come down and speak to this group, this is a daunting task. And what I did actually last night after Dr. Francomanos and Dr. Green at University of Maryland, the recent journal publication, which is fantastic, and actually better described a lot of what I wanted to say than what I was saying. So I excerpted some of that, and I'll appropriately credit that. But I wanted to actually include that in some of what we're going to discuss. So I left this as a fairly straightforward discussion of how veins and POTS go together. And then I wanted to leave time for discussion, and I'm very open if anybody wants a different level, more complicated, less complicated, better or fuller discussion of any of the things that we bring up. I also specifically did not discuss medication therapies for POTS. I think that's a different topic, but I am happy to address any concerns, and certainly a lot of people in the room could help me if there's any controversy. So causes of autonomic dysfunction in Ehlers-Danlos, and again, this came from the recent publication excerpted from Hakim et al., and certainly Dr. Francomano and Dr. Pasinki are part of this particular publication that was just published in 2017, this past month. So some of the causes that we see and that pertain to this discussion include low blood pressure, increased peripheral venous dilation, which causes blood pooling, and low circulating blood volume. And medications that can trigger or impair autonomic responses like tricyclics, like SSRIs, like clonidine, like some of the medications that may be used to treat other aspects of POTS. Elevated circulating catecholamine levels, autoimmunity, excess systemic histamine levels, and rarely brainstem or cervical cord impingement, as we heard, things like Chiari malformation or craniocervical instability, really anything that changes the pressure within the brain can certainly trigger a dramatic autonomic response and can actually trigger, frankly, EKG changes that we see on the 12-lead tracing that we put on just to measure somebody's electrical impulses. So when you have changes within the brain pressure or brain structure, you actually get such a huge drive, you can actually see changes that show up and may be dynamic on the EKG. And we do believe that leads people to increased vulnerability to arrhythmia. So symptoms can be highly debilitating, and this is symptoms of autonomic dysfunction or orthostatic intolerance or POTS. So the association of POTS with fatigue, reduced quality of life, migraine, and syncope in patients with joint hypermobility syndrome compared to those without. In other words, it's worse in people who have joint hypermobility than people who have POTS symptoms without joint hypermobility. Many symptoms relate to changes in posture. Some of the symptoms may improve, but not always completely relieved by sitting or lying down. Symptoms that suggest cardiovascular dysfunction include fast heart rate or palpitations, a fluttering sensation, lightheadedness, sometimes near syncope, near fainting, visual impairment, including altered acuity, partial or complete visual loss, light sensitivity due to pupillary dilation, cognitive complaints including word-finding difficulties, limited concentration, and poor memory, many of which people describe as brain fog, or just difficulty thinking, or how Laura described, you just can't get enough to get through what you're trying to get through, to even think through what you're trying to think through. People describe swelling or discoloration, maybe a dusky purple or red color in the legs after standing for relatively short times, and even when they're just dangling their legs down. So sitting, even sitting on the side of the bed for a little while, you can see the feet actually turn a purplish red color, and when you lift up the feet, they turn back to pink. And that would signify vein problems. Fainting, certainly that's an extreme example, but it happens, and that would be something that should raise cardiovascular concern and cardiovascular assessment. Temperature dysregulation or sleep disturbance. So collagen is part of many of our structures, including veins. Veins have 6 to 8 times the compliance of arteries. The structure of veins is similar to arteries. It has 3 layers. Both the veins and the arteries have these layers. The veins are much thinner and have less muscle. There's 3 layers: the tunica adventitia, which is a strong outer covering of arteries and veins that consists of connective tissue, collagen, and elastic fibers. The tunica media, which is the middle layer and consists of smooth muscle and elastic fibers. This is much thinner in veins. And the tunica intima, which is the inner layer, which is in direct contact with the blood flowing through the vein. It consists of smooth endothelial cells. The hollow center through which blood flows is the lumen. Veins also contain valves which prevent the backflow of blood and aid in the venous return. So when you think of connective tissue weakness and you look at these 3 layers, you can see that in different genetic disorders in different parts of collagen formation, you could affect all of these layers or some of these layers, and you can certainly see differences in how the support might be and how weak it might be. And again, when I look at Ehlers-Danlos, I see a huge variety of presentations, probably because it is many, many different gene presentations and many different expressions of those genes. And again, when you look at the structure of the veins and arteries, both are going to be affected, and to what extent they're affected is really going to regulate, how sick somebody is. So when you look at veins, and I picked the inferior vena cava because we do echo, because I'm a cardiologist, and when you look at a normal vein, this is the inferior vena cava here, which is filling into the right atrium or the top chamber of the heart. So blue blood coming up from the legs, filling the right atrium, and this is your tricuspid valve over here. So you can see that this is a nice sized vein. It's about 2 centimeters. What's happening here is we ask this person to take a sniff. And when you sniff, your veins are very thin and weak. They should compress. The arteries don't compress. So this is what we generally see. Now, one thing that got me interested in the first place with Ehlers-Danlos and POTS patients, and actually we've seen this in just some of our inappropriate sinus tachycardia patients, is the way this vein looks on echo, which I still haven't completely understood, but I'm going to show you. And we have a list of at least 40 or 50 people that have these veins, and when we look back, most of them are hypermobile. Some of them are thin women with high degrees, MDs, PhDs, highly functioning thin women who have inappropriate sinus tachycardia, and that's why we're seeing them, and may or may not be hypermobile. But often, so this is our patient that I selected to show you. Often the vein is much more dilated or distended in every way that we look at it. And when we watch the vein flow and have them sniff, it doesn't actually compress, it stays dilated. So the diameter of it stays dilated, it's not compressing, and you see the spontaneous contrast. So the spontaneous contrast is what's so fascinating, and we see that only in these patients. Haven't found any patients without inappropriate sinus tachycardia or hypermobility, or POTS that we have seen this in. So it's, it's unusual because the spontaneous contrast usually goes with a sluggish flow. And when we see it in the other side, it goes with sluggish flow. And it's not described anywhere. It's something that should be described. But when you look at it, you see it, right? Does everybody see it? So again, you have, swirling of blood that makes spontaneous contrast. This patient doesn't have an IV. These are outpatients. There's nothing being injected. It's just the way the blood flow goes. And every time you look at these patients, we see this. So again, it could look like blood pooling or particulate matter or just plain old sluggish flow, but it's there. And it makes a lot of sense when you look at the collagen structure and the complications that people see, and maybe even that some of the clotting issues that we see. So I wanted to describe pooling from, this was lifted off the web from Lethargic Smiles, but it describes what I hear in my office when people describe issues they have with blood pooling and people who get purple legs. Imagine yourself jamming items into a bag. The bag stretches and stretches and it gets heavier and heavier. In the case of venous pooling, it is a similar situation. More blood is pooling in my legs than they were meant to hold. It is quite painful. I think perhaps the pain comes from my skin and muscles trying to accommodate all of the extra volume, much like that bag trying to accommodate more items than it was meant to hold. It also feels like someone strapped 3-pound weights onto each of my legs. Each step feels heavy, as though I'm walking in water up to my thighs. I know 3-pound weights aren't much, but they are when I'm fatigued. My legs are already in pain, and I didn't choose to put them there. Then there's the appearance of venous pooling. My feet turn bright red, and after about 5 minutes or so, the veins begin to bulge. It's not attractive. My legs aren't the only place I feel the venous pooling. All of that blood being trapped in my legs by the pull of gravity means that the rest of my body isn't getting enough blood circulated to it, including my brain. So, and this really goes with some of the things that Laura described and some of the things that we hear and correlate with people that have these changes. So management, which is perfectly described again in the Hakim paper, avoiding or reducing exposure to triggers, withdrawing medications that might worsen symptoms, hydration and salt, reducing venous pooling by lower limb elevation or by abdominal and or lower limb compression garments, exercise adapted for joint hypermobility, instability, and injury. Exercise needs to be adapted for orthostatic intolerance. What do we mean by that? So the modality, aerobic with a local resistive component for the lower limbs, such as recline cycling and swimming. Definitely aerobic tolerated much better than isometric. And isometric means heavy lifting or resistance movements, where aerobic is more the conditioning. And again, for the arteries and veins, cardiac conditioning is extremely important. So I want to take a minute to emphasize that. 30 minutes, 3 days a week is really what it takes to condition the arteries and veins to have memory to the conditioning. So if you do 2 days, you're really starting over every time you do it. You really need the consistency more than the intensity. So it's much better to do things the best you can do for a more consistent, more prolonged period of time than to start over every time and to get behind because you just went out and did everything you can do. So this is really important that you actually take the time and consistency as your primary part of the exercise program, and then work more on the on the intensity of that. So prevention of peripheral pooling during exercise will make you be able to do more and feel better during the exercise. So if you exercise in the supine position, it may be better tolerated than the upright position. Exercising in water can decrease peripheral blood pooling because of the greater pressure exerted by the water on the lower limbs. Also, in this population, the pool exercises can be very important both because heat is not well tolerated and because direct joint pressure isn't well tolerated. So for somebody with uncomfortable joints, the pool may be a comfortable place to exercise. So you don't want to do an arthritis pool, which are the high temperature pools. You want to do a regular temperature pool because the cooling is going to be an important part of tolerating the exercise. So avoiding or reducing exposure to triggers is one of the most important parts of management. Withdrawing medications that can worsen the symptoms. Again, I don't want to forget those. Back to exercise, the intensity and frequency of the exercise we talked about, but the target heart rate recommended should be 75% of the estimated maximal for about 30 minutes per session, 2 to 3 times per week, and I would go more toward 3 times per week. Increase the fluid intake, preferably with added sodium. Pressure garments during and after exercise. Avoid meals 1 hour prior to an exercise session because vasodilation in the gastrointestinal tract lowers the capacity of the circulatory system. Prevention of a sudden drop in blood pressure after training by engaging in low intensity cool down. So always a warm up and a cool down. Many people say they can do more when they warm up and they feel better when they cool down. If you go too hard and then stop, a lot of people actually get behind. They get exhausted and they can't get back to it fast enough. In those with moderate to severe impairment of daily function and poor response to or tolerance of the non-pharmacologic treatments, the pharmacologic treatments then become available. And that's really, you want to try everything possible not to need the pharmacologic treatments. One thing people tend to do is forget the compression. And again, because we're talking about laxity in the veins, it's a support issue, right? There's problems where you just have pooling because the tissue is weak. So if you wear the compression, you're going to make up for a small part of the pooling, and you don't want to forget that. So even if you're doing well, you're on pharmacologic therapy, or you want to get into pharmacologic therapy, don't forget the compression. And it's become much more available and wearable, especially in teens, as it's become popular with athletes. So honestly, the athletes liking compression clothing has made it wonderful for POTS patients. So I had years where teenagers that we see would never wear the stockings, right? You'd get them through maybe a month or a week. They feel pretty good. They're doing okay, but they would never wear them, and they certainly wouldn't wear them to school. Now the cool kids are wearing the compression stuff. They sell it at Dick's. They sell it on the web. They have cool stuff. They even have colors. So this is going really well. And things that work include Spanx, men's compression underwear, anything that goes around the middle works. I don't recommend that during pregnancy, but otherwise it actually has much better effects. And anything that helps you in the thighs is going to help your veins. So vascular Ehlers-Danlos, I just want to take a minute to separate that from the other groups, because when we're talking about arteries and veins, the fragility of those vessels is more extreme. And again, the collagen mutations are very clear and can be very severe. In these patients, veins are very, very superficial. They're very fragile. Varicose veins are more common. And certainly there's more and better described pelvic pooling that you can even see on some of the imaging. So again, just examples of some of the veins so that you can see what they look like. So venous distensibility, mechanical effect of the laxity in the connective tissue. Most effective treatments are going to be the mechanical treatments and positional treatments because this is a mechanical or structural problem. Adjustments at this time include support and positioning, temperature regulation to avoid venodilation, hydration and salt to support volume, and pharmacotherapy can help avoid venodilation and support veins with volume. So I wanted to open it up to questions and discussion, which certainly can be veins or more than veins.
Dr. Fisher, this is excellent. Thank you so much.
Thank you.
One for the venous pooling, one thing that we noticed in some patients with the injection with the long-acting high progesterone contraceptives, like some patients they get progesterone mainly, which is rightly they do most of the time in order to it's better hormonal. At least measurement of contraception. Those patients, interestingly, the more progesterone, they have more venous pooling. And some patients just by, like I don't know how many of your patients that you showed those small pictures are, if they are in contraceptives, what contraceptives they are on. And because some of our patients, we just told them, look, we want you to get off the progesterone combination, and we put them in estrogen, like even higher estrogen, and they did their symptoms of venous pooling ameliorated. I don't know if you have similar experience to that.
I have had similar experiences, and again, I work with a lot of maternal fetal medicine people through the congenital heart group as well. So we have a lot of issues with sort of who has clotting issues, who can have estrogens, who can't have estrogens. But in the patients that can have estrogens, sometimes the estrogens do help support the vascular tone. And that can be very helpful. In the patient that really can't have systemic estrogens because of clotting problems or significant varicose veins or concerns for prior deep venous thrombosis, or central venous thrombosis, where the estrogens are really contraindicated. We've had great success with the IUDs. And again, in the vascular Ehlers-Danlos patients, that's a little bit more iffy or even, relatively contraindicated because of the thin uterine issues. But in the hypermobile Ehlers-Danlos patients, and in a lot of our congenital heart patients, they've been fantastic. Number one, over time, they actually decrease how heavy the menses are. They decrease some of the cyclic problems that people get with the onset of their menses. And you don't see any of the pure progesterone effects. So that has really been sort of my choice recommendation for a lot of these patients.
Amongst the population of patients, young women in particular, presenting with vasovagal syncope or other types of syncope, and with neurally mediated hypotension, what percentage would you estimate have Ehlers-Danlos syndrome or some other similar connective hypermobility connective tissue disorder?
So I would say there's a much, much bigger population of pure vasovagal syncope. And, again, I'm in a skewed world, but in my world, we bring them out by compressing the groins or, post-procedural blood drawing type things where they may not have any other issues or any other sensations or any other hypermobility. So I think the number of patients with syncope, the vasovagal syncope as a pure state is going to be the most common. Outside of that, I think that I think it's hard to say, and again, I think I see a skewed population, but probably about a third of the patients that come in with pure POTS have hypermobility Ehlers-Danlos syndrome, and a very, very small percent are actually vascular Ehlers-Danlos. More of the vascular patients we meet through our aortic disease center. So I participate in an aortic disease center where we look at and monitor changes in blood vessels if we're worried about aneurysm or blood vessel dilation over time. That's generally an arterial side of disease. But many of the patients with vascular Ehlers-Danlos who have actually gene changes of vascular Ehlers-Danlos show up through that route. Sure.
I was wondering, in POTS patients with the compression stocks, have you seen decrease not only in the venous pooling but also in their symptoms of like dizziness and sensitivity to barometric pressure changes as well?
Yeah, absolutely. You know, the primary thing we're trying to treat with compression is actually the central symptoms. So you're trying to prevent some of the pooling in the first place. So if people actually put on the compression before they really get up and get going, you can prevent some of the pooling. It's not that you have an absence of pooling, but you can decrease the symptoms. You can have more upright time. You can have a better experience upright. So again, a lot of this is going to be management of a chronic condition. And if you do that, plus avoiding the triggers, plus the temperature control, if it's going to be really hot out, you limit your time in the heat, or you bring coolers with ice wraps. But you do things to try to mitigate the symptoms. I think you can really cut down and avoid some of the medication therapies that way. And again, I wouldn't want to do the medications without the compression, because the compression makes a huge difference and really may make all of it more successful.
Thank you. There wasn't a discussion about this exactly, but have you found that in your patients that can tolerate it, that you can improve venous return not just with compression stockings, but also with increasing muscular tone, generally in the legs?
Yeah, as far as exercise, absolutely. And again, that's what I was saying, that the exercise you want to do needs to be very consistent. So you really need 3 days a week, you know, goal of 30 minutes as a minimum to get the conditioning, to build the tone, to improve the tone in the muscle part of the vein and artery structure, right? And the whole cardiovascular system. So you want the regular, consistent aerobic exercise however you can get it, and obviously that would have to be modified based on orthopedic limitations.
But additionally also focusing not just on cardiovascular exercise, but increasing actual muscle tone in your, I mean, like for patients that are active every day and they try to build in not just cardiovascular routines, but toning of their muscles in their legs. I mean, like calf muscles, those, I mean, specifically targeting specific areas.
I haven't seen anything published, and I don't know how you decipher that from the vessel tone versus the muscle tone around the vessels. You know, I think we count on both, and I don't think it's clear from what we know yet if it's the muscle squeezing the veins, you know, and the stronger muscles are actually giving you better support, or if the veins themselves get stronger and more supportive. I don't know how to decipher that. I do think that we see, you know, the measurements are more measurements of like brachial flow reactivity, symptoms, blood pressure in the upper body, trying to maintain a better blood pressure in the upper body, duration of standing before the symptoms really get too bad that you can't.
We often aggressively hydrate our patients for low blood pressure post-operatively. We're sort of shooting ourselves in the foot by increasing blood volume that much where they would tend to pool more? Or do you think aggressive hydration is the right thing to do?
So I think as long as you have normal cardiac function, the aggressive hydration is necessary, because you're trying to combat in that setting anesthetics, which dilate the vessels a lot. So you're going to need that to actually make up for that. You either need to aggressively hydrate them or use, you know, arterial constrictors. So, you know, I think the saline is much better, or the, you know, saline or colloids are going to be much better than using things like phenylephrine to vasoconstrict or venoconstrict. And again, you have profound vasodilation in people that are already vasodilated because of the anesthetics, and you certainly need the anesthetics. So, and again, I think as the data gets better, there are things like in cardiac surgery, we use methylene blue coming out of surgery to vasoconstrict. Is there a role for something like that? I don't know. But there are a lot of considerations and parallels between the multiple disciplines. And again, that's why I think the multidisciplinary thought process like this is fantastic. But I think the standard would be to aggressively hydrate, and I don't think we have better than that at this point. Sure.
You didn't talk much about nutrition. What are your thoughts about protein?
I love protein. Protein. So first of all, with nutrition, one of the, one thing that I think we need to be really careful about is energy, because people seek energy, right? And currently there's a lot of targets, for energy, like energy drinks, right? Which really have a lot of negative consequences to the cardiovascular system. So I think when people don't feel good and they're seeking energy in our current world, they're targets, and I worry a lot lot about that. So I want to take it
more about meat, fish, and chicken.
I'm getting to it, but I wanted to stick my thing in there, which is I'm afraid in this population about things like energy drinks and some of the supplements that people are looking toward to try to get energy that may really have negative cardiovascular effects. Positive cardiovascular effects, the high protein diets are going to be extremely helpful. And again, when you talk about things like brain fog, the carbohydrates are going to contribute to that significantly. But there are a lot of people with digestive problems and gastroparesis, with Mouse syndrome, median arcuate ligament syndrome, with a lot of comorbidities that may really change the way they can do their diet. So the healthiest diet is going to be high protein, small frequent meals, right? But you do need enough calories, and you do need enough hydration, and you do need enough salt if you run low blood pressure. So salt in general is only bad because people run high blood pressures. Some of these patients actually, I think, come into care because they want to get healthy, and they try to limit their salt, and they go on a low salt diet. They want to lose weight or get healthy, and they decide to follow a fantastic like paleo or clean eating diet, and there's no salt, and they start fainting, and that's where they show up. So I have seen that a whole bunch of times where somebody isn't diagnosed with Ehlers-Danlos and they show up fainting because they want to be healthy, and they are following a healthy diet for somebody who's normally excreting salt, who normally has who has normal or high blood pressure, but they can't tolerate that. So again, in this population, you need to know your blood pressure, and you need to know if you have postural effects. And if you do, you generally need to keep the salt. And again, we want to keep the salt that they need to stay upright and feel good, but not so much salt that they have high blood pressure. So the protein's important. The balance of foods and nutrition is very important. Not only to POTS, but to how they feel. In POTS itself, the biggest issue is going to be salt. So it's even more than the protein or carbohydrate balance, it's going to be salt. And with all of the digestive issues that are that are really variable in this population, I don't think you can actually give one diet, but I do think you have to look very carefully at the balance of the diet. I don't know if that answers the question.
My question was, I've been reading about perhaps pushing for half the body weight in grams of protein per day. Is that too much protein?
It depends. Again, if you have kidney dysfunction, that's too much protein. If you're trying to do a high protein, low carb weight loss diet and you're going to drink enough water to get it through, then that's a great amount of protein, right? So, but in general, and then if you have that much protein plus a full diet, you're going to just build, and, you're going to build muscle, but you're also going to build weight rapidly.
Right.
So I think you really do have to look at the balance of the diet, and you have such a diverse group of issues with diet that I don't think we could we could make that something that is right for everybody.
Thank you.
Sure.
I've been giving people after surgery, after hydration, 6 grams of sodium, of salt a day. Now, salt pills make people nauseated. You give them before meals with an anti-nausea medication, you find a few days of 6 grams of salt fix the problems. Then, about your video there, that vein didn't compress because it was not elastic enough, because it lost the elasticity.
I don't think so. Well, maybe. So, I don't know why, except that, there's pooling. So I don't know if it's because the volume in that vein is very high where the veins above it are actually empty, or if it's loss of elasticity and it just can't constrict. But that's, and I wanted to bring that here because we see that, and I don't have a perfect explanation for that. And this is the right group to figure that out.
That's something interesting in the European medicine. We don't have them FDA approved here. Everybody that gets a vascular surgery, even a bone surgery, because you remove and move a lot of veins there, goes home with some venotropic or venotrophic medication. Then those are flavonoids, like rutin, rutoxin, diosmin, and hesperidin. They are medications that are available in America at GNC stores, but not as pills at FDA.
And what are
And
they?
vitamin C.
So I don't actually know a lot about them. What do they do? Are they supposed to
Apparently
constrict?
somehow they make those veins elastic.
They restore elasticity.
Well, lutein is recommended for retinal problems. I recommend that all the time for patients.
Macular degeneration.
Yeah.
Yeah.
Yeah, I think we have a lot to learn. Yeah.
Yes, actually, Laura, go ahead.
Sorry, what is your understanding in the relation of mast cell activation disorder and autonomic dysfunction in POTS, whether it could be the mast cell that could be causing the POTS and autonomic dysfunction because of the toxic releases going on in the body? What is your understanding with that, do you know?
So my understanding, of mast cell activation really came through patients, and very classic cases where people went from completely non-functional to functional. But histamine is a substance that causes massive dilation of both arteries and veins, and can really drop the pressure very abruptly and very severely. And certainly, with anaphylactic reactions, it's very clear what you're seeing. With less than anaphylactic reactions, it's still happening to some extent and probably a variable balance. And again, with unstable mast cells rather than provoked mast cells, the timing and triggers for them, I don't think we understand that well yet. So I think that's really an emerging disorder that we're learning a ton about. I have found that the people that respond to mast cell therapy respond beautifully, and their POTS becomes very controllable by treating the mast cell disorder, because it can be a huge trigger for, they have to have the ability to have the positional changes. But if you can remove or get rid of some of the triggers, and if that's the main trigger for a particular person, you really can get a very controllable, very livable lifestyle. And again, I think the goal here is exactly the way you described it, is to get to a point where you can actually have a livable life, even though there's some obvious challenges that continue. You can function well, you can have a good life, you can deal with the challenges, and you have enough energy to deal with them.
Yeah, and I work from the hematology perspective, and work about on patients for say hypercoag disorder, etc. So, and the clotting disorder, we usually say, hey, look, it's a blood vessel abnormality consistency of the blood and the coagulation system. So I was just wondering, in some of the patients based on their risk factors and, and we do put some patient on, anticoagulation. I was just wondering, it seemed like from the, the IVC Doppler, it's the distensibility that causes the sluggish of the flow, and some of the patients, if they are on anticoagulation for various reasons, I'm just wondering whether you could see a mechanical change in the sluggishness of the blood circulation. And then I do appreciate the opportunity to take care of our EDS patient, and I do feel like I'm learning as I'm seeing more patients, and it's fascinating, and I do have some interesting observation of our patient and also their response to anticoagulation, and I do observe that when I use Lovenox in our EDS patient, and they don't have to have what our standard therapeutic dose of Lovenox to achieve a therapeutic level of hyperantennate level. So I think they are correlated with some, blood vessel difference in our EDS patient. It's handled by the kidney. Maybe there's some blood vessel difference that make this difference in how the antennate level goes, but they don't have to have a therapeutic dose to achieve a therapeutic level. So and some other phenomenon. So I just think it's really fascinating. But as I look at the IVC, picture, I was just wondering if some patient on anticoagulation, you could see a difference in the sluggishness, or do you have actually objective measurement of how sluggish the venous flow is?
So far we haven't done anything but collect maybe 40 or 50 cases, through just a single site echo lab. We haven't gone back and looked at, studies that were done outside or, downtown, or, just our one small site office. And we've, collected these over a couple of years, and we've been thinking about them. And again, I think, we should use them as a group in society and use them to provoke thought, because it's certainly a very clear association. And it fits with all of the things that we're seeing with the central issues, with some of the things the neurosurgeons are saying, and with POTS and just an etiology of POTS, and with what you're seeing in hematology, right? Because this would provoke clotting, because you do have sluggish flow. So it's interesting, and I think, over time it should affect our management somehow. And again, I think as a community we'll have to look at how. Yeah.
I think we might have to have more lectures on cardiology, because this issue of raised venous pressure is really important, and we see this a lot.
Yeah.
Raised venous pressure, not just in the brain, but in the superior vena cava, and failure of the IVC to collapse, and so on. And that brings us even to possible diastolic failure or diastolic problems, that or diastolic syndrome, that I don't think in medicine we've looked at very much. And so we'd love to have a lecture on that sometime, sir.
I think also there is a paper by Dr. Frank Camano that it was mentioned that some of these patients with EDS, they have elevation of their pulmonary pressures. And if you have showed that in one of the papers. So if you have, for the paper you showed, so in those patients who have elevated pulmonary pressure, if there is elevation of the, that there could be increased elevation in the right atrial pressure, and that could also increase the venous pressure. This is one etiology. We had similar experience to Dr. Fisher. Those patients that you showed, the dilated, we stood these patients for 5 minutes. And some patients did not constrict. Some patients continued to be dilated. The patients who were dilated were the most severe venous pool. They just, the etiology, as I mentioned, is not known, but you know, this is truly, there is this another phenomena that these patients are, as you mentioned, the distensibility of, the excessive distensibility may impede the venous return, and that could also decrease the cardiac output, and that could also be one reason for patients to be so tired and fatigued.
Thank you. Are you volunteering to give a lecture sometime? Thank you. Thank you all very much for coming tonight.
Thank you.
Bye.